All right, gang, we're going to do chapter 4, and we're going to talk about healthcare professions. So let me just get my slides up. There we go. All right, so health services professionals. So we've been talking kind of broadly about the system so far. What we want to talk about in this chapter, what you're going to read about in this chapter in quite a bit of detail, are the people that work in the system and the kinds of professions in the system. So I know some of you are interested in healthcare. So we're going to talk about different kinds of health services professions. I'm not going to go into quite as much detail as the book does, but I am going to kind of skim over what I think are the important points. So broad list of different types of health services professions. It just occurred to me, I left out veterinary service because we're generally speaking more about the human side of health services. But vets actually, so just kind of as a side, vets play an important role in public health. They are used as food inspectors so if you have they are hired by the FDA to look at processes for meat packing, so slaughter of cattle, for example. So when you eat your cheeseburger, you can thank a veterinarian for making sure that the food supply chain is safe. So we're going to focus on human side, though, for this lecture. So broad list of professions that I'm going to talk about, starting with physicians. So physicians. When you say physician, we generally think of MD, medical doctor. That's the dominant paradigm. We talked a little bit about history of our health system and how different professions have done battle with each other to try to monopolize the services. So the AMA is run by MDs, and they did their best as they got powerful to squeeze out all the other kinds of physicians. So we talked about how in the last chapter how early history physicians were kind of running all over the place, doing pretty much anybody could say, well, I'm a physician. Training was quite minimal. There were all different sorts of traditions that physicians came from, and so with professionalization, we saw a reduction down to just a few types of acceptable physician degrees. So the MD is the dominant one. The second most common one that you will see is DO, Doctor of Osteopathy. Slightly different tradition than the medical doctor, MD, a little more holistic, a little more concerned about the whole person. My sister is a DO. My father was an MD. I have a brother-in-law who's also a DO. My sister is a family medicine DO. My brother-in-law is an electrophysiologist, which is a subspecialty of cardiology, which we'll talk about in a second. So DOs do both family medicine, generalist kind of work, which is what your book talks a lot about, but they also are just as likely to be seen in the specialties today. So my brother-in-law being case in point. Cardiologist subspecialized in electrophysiology. We also have Doctor of Podiatric Medicine, podiatrists. Podiatrists are officially physicians. They go to podiatry school, but they are regarded as physicians. So if you see a podiatrist, don't make the mistake of saying that they're not a physician. That will make them very angry. And then we have some other I don't want to call them fringe, but much less common. So one example is naturopathic doctor, or ND. We've got one in Portsmouth. So for your that I did a podcast interview with. So if you're interested in truly holistic homeopathic care, really interesting interview with her. Let me know if you're interested in doing that one. So let's talk a little bit about physician training broadly, and this goes for all of the physicians we just talked about. Generally speaking, they get a BA or a BS. You don't have to have a degree in science. I've met physicians with degrees in history and English and all kinds of stuff. You do have to take a bunch of science to qualify to go to medical school. So they get a bachelor's degree, and then they go on to medical school for 4 years. And then you graduate from medical school, and you technically are a MD or a DO at that point. And so you could conceivably practice. Nobody will hire you these days, but that's a relatively recent thing. Today, the most common paradigm is you leave medical school and you go to a residency, and we will talk about residency in a minute. But and there are a whole variety of residencies. And then if you want to do further specialization, you do a fellowship. And typically, following the residency as well as fellowships, the physician will take board certifications in their residency, and then further in their subspecialty if they do a fellowship. So broadly, when I think about physicians, I break them into 4 groups: medical, surgical, psychiatry, and hospital-based. This is sort of more, I mean, you'll see different ways of categorizing, but I think this is a useful way of thinking about them. So let me talk about these different types. So within the medical kind of, and the difference is, so medical subspecialties focus on the use of diagnostics and medicine. So the use of pharmaceuticals, manipulation, other techniques, basically non-surgical. I guess that's the right way to say that. Not generally non-surgical, though some of the subspecialties that are in the medical field actually do many procedures, and so they are kind of surgical. So it's not a clean divide between, medical specialties only, do medical treatment, and the others, and then surgeons do surgery. Like I mentioned, my brother-in-law is a cardiologist with a electrophysiology subspecialty. He does a lot of invasive work where he implants pacemakers, for example. So he does surgical procedures as part of his practice, and that's where a lot of his income comes from. But we generally kind of, within the medical field, we have primary care. And that consists, typically we think of primary care as family medicine, pediatrics, and internal medicine. But we also have, within that medical field, we have specialties like neurology, the study of the brain and nervous system; dermatology, study of the skin and related diseases. And then you have internal medicine and internal medicine subspecialties. So let's talk a little bit about that. So these specialties do an internal medicine residency first. So if you're going to be a cardiologist, you go to you get your BA, then you go to medical school. So that's 4 years. Then you do a internal medicine residency. That's 3 years. Then you do a cardiology fellowship. That's another 3 years. And then if you're going to be somebody like my brother-in-law, you do another year further fellowship in electrophysiology. So that's another year. So that's a total of 7 years of residency and fellowship training on top of 4 years of medical school. So 11 years of medical training to do that one specialty. So all this list, and there's more, start out by doing an internal medicine residency after medical school, and then they go on to do fellowships in one of these fields. Endocrine specializes in the endocrine system, so it's glands, and so this would be like if you have diabetes, you'll be followed by an endocrinologist. Gastroenterology, GI, so this is the digestive system. Hematology, blood. Infectious disease is, COVID, by the way. Nephrology, kidneys. Oncology, cancer. Pulmonary is, breathing. And then there's more. The surgical subspecialties, you start with general surgery, hence general, right? But that's, and then you can go from general, you can do further fellowships in other subspecialties. You also have other surgical specialties. So you do orthopedic surgery is its own residency. So you can do general surgery as a residency or orthopedics as a residency. But if you do orthopedics as a residency, you can then do a fellowship in spine, hand, or hip to subspecialize as an orthopedic surgeon. Urology is a subspecialty, or excuse me, is a residency by itself. Plastics, so we often think of nose jobs, boob jobs, butt jobs, things like that. But plastics is really dealing with the skin, and so plastics on the kind of the non-cosmetic side are really important if you get into a car accident and they need to rebuild your face, for example, or if you're a burn victim. Plastics work with burn victims. Ophthalmology, surgery on the eyes, neurosurgery, surgery on the brain. So psychiatry kind of stands by itself, a unique focus on mental health. Psychiatry versus psychology. So this is an important distinction. Psychiatry are physicians. Psychiatrists are physicians. Psychologists are not. Right? A psychologist gets a PhD or a PsyD, a doctor of psychology, and they can do therapy, talk therapy. They can do a lot of other important functions, but they can, generally speaking, cannot prescribe medications. So your psychiatrist, if you have a mental health issue, say chronic depression, you're probably going to be followed by a psychiatrist as well as a psychologist or a therapist of some sort. So you'll have a therapist doing working with you on working on your ideation, and then you'll have a psychiatrist who will manage your medicine. And so psychiatrists can do therapy, but they generally don't because they make a lot more money managing medications. And they uniquely can do that. And this is one of the things about healthcare is we see a lot of kind of subspecialization. Psychiatrists could do therapy, but they would make significantly less money if they spent their time doing therapy rather than pharmacological management. And so the typical psychiatrist is primarily focused on the management of mental health through the use of pharmaceuticals. So hospital-based. So this is kind of a weird idea, but there are physicians that basically are heavily engaged in the use of technology or hospital facilities. So emergency medicine physicians basically operate in an emergency department. They need all that equipment and they need that environment. They're trained to operate that environment. And so that's where you're going to see them, is in a hospital, in an emergency room. Radiology, right? A radiologist needs to use the various scanners and other equipment that is provided in a hospital. Pathology is the study of disease. This was my father's specialty. So they operate and supervise the laboratory functions of a hospital. They also do diagnostic work. So if your oncologist suspects you have cancer, for example, a surgeon would do a biopsy, send that to the pathologist who would then look at it and make a diagnosis. Yes, this is malignant cancer, or no, it's not, or it's benign. And they provide that feedback. Anesthesiology, right? Your anesthesiologist is the person that passes gas, as we like to say. They're the person that manages your pain and knocks you out during surgery. So your book talks about a problem in the balance of providers in terms of we have too many specialists and not enough primary care. So I've got here to show you what physicians earn. And maybe you can figure out why we have so many specialists. So your primary care, typically we think of the three main primary care providers are family medicine, with or without OB, pediatrics, and internal medicine. So you can go do an internal medicine residency and then decide, I don't want to be a cardiologist, or I don't want to be a hematologist. I just want to be a adult doctor. And that's what an internal medicine generalist is. So you can see this is the median income. So half of the population makes less than this and half the population makes more than this. This is from an organization called the MGMA, Medical Group Management Association. And they do a survey. They are the professional organization for medical group management, so for physician practices. So you can see this is the length of the residency. So 3 years, so total of 7 years of training gets you into the $250,000 range. Your book says that these folks do most of their training in an outpatient setting. That's not correct. Most training even for primary care specialties is hospital-based. And the reason that it is because patients who are admitted to the hospital are more sick, more complex, and therefore are better for training. And so my sister, who's a family medicine doc, who never spends time in a hospital now that she's done, did the vast majority of her training in a inpatient in the hospital, taking care of patients who had been admitted to the hospital. She did do some clinical work, but the vast majority of her training was on the inpatient setting. So that's something you should kind of understand your book gets wrong. And this, I know a lot of physicians. I've done a lot of them. I'll talk more about that, as time goes along. But it's just, your book is just wrong. Pediatrics, same thing. Internal medicine, same thing. What's interesting is if you graduate from one of these specialties, you are qualified to be a hospitalist. And what a hospitalist is a person that manages patients in the hospital only. So it used to be, if you got sick enough that you needed to be admitted to the hospital, your family medicine doctor would order you admitted, and then she would show up each morning and each evening to check on you and to place orders with your nursing staff to say, I want this and this done to the patient, and then report to me if there's any problems. Today, that has, over the last probably decade, that is mostly phased out. And most family medicine doctors no longer do inpatient care. Instead, what happens is your family medicine doctor will admit you to the hospital, and then your care will be taken over by a hospitalist who is either, most of the time, either a family medicine doctor or an internal medicine doctor whose sole practice is in the hospital or has a primary practice in the hospital. And so there's a handoff between your family medicine doctor and the hospitalist. And the hospitalist, basically the hospitalist practices, they show up, they pull a 12-hour shift. That's pretty common. And then they go home, and they don't have call, and they don't have, and they treat you while you're in the hospital, and they make your plans and they work with you. But then when you're discharged, you probably never see them again. And you go back to care with your family medicine doc or your internal medicine doc. So this has become the dominant paradigm in hospitals, is outpatient doctors no longer follow, outpatient primary care doctors no longer follow patients or care for patients in the hospital. There's a subspecialization. Now notice the difference in compensation. So this is, these are primarily outpatient, right? Taking care of patients in an office setting. And this is long days, hard work, lots and lots of dealing with electronic health records and a bunch of other annoying things. This option, the hospitalist, basically you come in, you do your shift and you go home. It's a pretty good deal. And that's why a lot of hospitalists like it. The thing that attracts people to primary care is the longitudinal relationship. And so that's what you lose if you're a hospitalist. So people who like being family medicine or like doing internal medicine like to get to know their patients over many, many years. And so my sister works in a city clinic in Philadelphia. So she deals with the very, very poor. And she gets to know her patients over multiple years, and they have a relationship, and that's really meaningful to her. A hospitalist, you're a hired gun. You deal with the patients while they're in the hospital. And then when they get discharged, you're done. You kind of, wash your hands and off they go. But notice the higher compensation, and that's because inpatient stays are really expensive and they generate more revenue. And so the hospitals pay the hospitalists quite well. So that's primary care. So let's look at, just kind of look at the numbers here for specialists, right? Who's the low paid person is ophthalmology. Again, this is ophthalmology is eye surgery. So this is not an optometrist. This is an ophthalmologist. So this is a person. So optometrists primarily do, glasses and some basic diagnostics, but ophthalmologists treat surgical issues. So they're surgeons. So you're not going to go to see an ophthalmologist for your glasses. You're going to see an optometrist for your glasses. 400,000 is not too bad, especially since, look, it's 1 year longer in training than, say, a primary care doc. So you're going to make, 75% more on average than you would if you were a primary care doc by doing 1 more year of medical training. So 8 years instead of 7 years in total. But look at the colleagues, right? Cardiology, if you do 6 years of training, you're going to average making 530,000, GI 536, right? So what we have here, so I was talking about my brother-in-law did a internal medicine residency, then he did a cardiology fellowship, then he did a further fellowship in electrophysiology for a total of 11 years of training. The average electrophysiologist makes $683,000 a year. Right. You can also see down here. So, for example, orthopedics, if you do an orthopedics residency, 5 years, the median orthopedist makes 619,000. But if you do a spine fellowship, you can make a median of 835. Okay. So a lot of these, so surgeons work really, really hard. They work long hours. Orthopedics surgeons, part of why they make so much money is they work long hours. So we're not kidding around here. They're making, they're making a ton of money. They're also working 70 hours a week. So if you like that lifestyle, and you like to be up at 4 a.m. to get to this, to start surgery by 6, that's something to think about. It's a hard life, but it's a well-compensated life. This is also a hard life, by the way. So I had one pediatrician say to me, because she was working in leadership for her organization, and she knew how much the specialists were making. She's like, the subspecialist works hard, but doesn't work 3 times as hard as I do. And so there's some resentment within the field between this primary care and the specialists. So why do we have so many specialists? Well, it's because they make so much more money, for relatively not that much more training. Like, I mean, if you think about it, if you're already doing 7 years, what's 10 years, right? Or better yet, what's 8 years versus 7 years? So people who go into primary care do it for a passion. They love people. They want to take care of people. So my sister, really passionate about taking care of the poor. She doesn't make that much money because she works for a city clinic. So she's on the lower end of that. But to be a primary care doc requires a lot of passion for what you do. The other thing here is the way physicians are compensated. We'll talk more about this in the chapter on finance. Is they're compensated based on how much the government says they should be compensated per unit, and that per unit payment. So they get a fee for service payment. So most physicians are paid on how many patients did you see and what did you do to the patients? And the AMA, the American Medical Association, works with the Center for Medicare and Medicaid to come up with what's called an RVU scale. And I'll talk more about that later. But basically what between the government and the American Medical Association, they kind of decide who's going to get compensated more. And so this is part of government policy. This is a direct result of government policy. So when your book talks about, gosh, wouldn't it be great if the government, had more to say about how much, about how healthcare runs? Well, they already do. And the distortion that they create is not enough primary care docs and too many specialists, relatively speaking. All right. So we talked about physicians. How about mid-level providers? So my primary care person is actually a nurse practitioner. She's a family nurse practitioner. So we see these, so we refer to physician assistants and nurse practitioners as mid-levels or mid-level providers. So they are not physicians, but they do have the ability to do diagnostic work and then treatment. And that's a difference between a mid-level or a physician and some of the allied health. The allied health are not have less diagnostic authority a lot of times. Mid-levels are more about managing patients. PAs and nurse practitioners. So typically we're talking about a master's level training. So a nurse practitioner, you have to be an RN first. So you need your BSN 4-year degree, and then you go on and get a 2-year master's degree that confers your nurse practitioner status. But you can subspecialize just like physicians can. So you can be a family nurse practitioner, or you can be a psychiatric nurse practitioner. I worked with a lot of PAs and PA training when I was in the military, and we had, orthopedics PAs, right? So PAs who did their PA degree and then went on to do further training in, say, orthopedics or surgery, and they work with, say, orthopedic physicians, orthopedic surgeons to support them. So those are interesting. Nurse midwives. So you can have a midwife is a nurse midwife. So you're RN, and then you get a master's degree in midwifery. You have, if you've had surgery, you might have had a CRNA, a certified registered nurse anesthetist. So that's again an RN who's gone on to get a master's level degree in anesthesia. Critical to the healthcare system are nurses. So you typically have what we think of as the RN, the registered nurse. The most common today is the bachelor's level nurse, but historically, to become an RN, you could do a diploma, 2 or 3-year degree. So basically an associate's degree, often run from a hospital. And then you would get your RN. So all mid-levels, like I said, the nurse practitioners and so forth have to earn their BSN first. You also have a lot of non-RN nursing staff, licensed practical or vocational nurses, depending on what state you're in, known as LPNs and LVNs. They have some level of authority to hand out medication and do some higher level things. Then your nurse aides or certified nurse aide, CNA, or licensed nurse aide, LNA, all critical to the provision of healthcare. Pharmacists. So, if you get drugs, you get them from a pharmacist. Probably most of your interactions with them have been, at CVS or Rite Aid. They're there to verify the medical necessity and make sure that you understand the medicines you get. Historically, pharmacists actually made the medicines, right? So so there's a thing called a compounding pharmacy, where the pharmacist actually mixes stuff up. So when you see, one of the symbols of the pharmacist is the mixing bowl, mortar and pestle, where they would be, grinding and mixing medications for you. Today, that's not so much done on the outpatient side, but it is very much done on the inpatient side. And you can have subspecialties within pharmacy to include oncology, nuclear medicine, a bunch of other cool stuff. So you have a very different practice in the outpatient kind of Rite Aid, retail kind of setting, and the inpatient side. If you're an inpatient, you're going to probably be on IV medications. Who's making that up? The inpatient pharmacist is mixing up medications and then putting them in your IV bag for you. So that's an important, critical role that pharmacists play in the inpatient side. Dentists, right? So we're not going to spend a lot of time talking about dentistry, but it's important. Oral health is a really important function. Dentistry, the dental training, you're either a DDM or a DDS. It's 4 years of training, and then no residency required to be a general dentist, but you can then go on to, but if you want to be an oral surgeon, so pull out, if you've had your wisdom teeth pulled, that would be an oral surgeon. You can, if you've had braces, you can be an orthodontist. You're probably too young to see a periodontist, but as you get older, you might need to see one to deal with problems with gums. Prosthodontics. So hopefully, again, you're probably too young for that, but someday you might need false teeth. Maybe your grandparents have false teeth. So those are the specialties within dentistry.
Okay, so the next category of providers that I want to talk about, or the next of health professionals that I want to talk about, are allied health. And I break allied health down broadly into two categories: those who have a license to practice on their own, and those that provide care under the license of someone else. And allied health is kind of this grab bag category of people who are like therapists, as well as people who are technicians of various sorts. So the first category, the licensed independent providers, LIPs, if you will, I include people like physical therapy, occupational therapy, rec therapy, which is a really cool thing that if you're thinking you might want to be a clinician, this is something to explore. We have rec therapy in our college. Clinical social workers. We have social workers who do not do therapy, and then we have social workers who can do therapy on their own. And then psychologists, clinical psychologists. So these are individuals who have been trained in various ways to provide healthcare, but are not physicians, right? And they're not nurses or like I said, not dentists and so forth, but they are able to bill for their care on their own. So a physical therapist, maybe some of you have seen one, right, takes care of those kind of broad motor skills. And so they bill for their care. The next category are kind of the other, and this is, like I said, kind of a grab bag. Many other people who do not have or providers and provide care. So you don't want to say that an occupational therapy technician, an OT tech, is not a provider. They are indeed a provider. They just don't have a license that allows them to practice on their own. They have to practice under the guidance of a licensed individual provider. So you have lab techs that work in the lab, and you have different levels. You have the technologists and the technicians. You have OT OT techs, PT techs, radiology technicians that have different levels of skill. So you have kind of your basic rad tech that does X-rays. You have a kind of higher level that might do MRI, CT, and various other. They know how to use the equipment to do radiology procedures. A radiologist typically does not come in and set up the X-ray for you. That's done by a technician. So lots of these kinds of people, if you go into a hospital, that they may have a license and they may have a certification, but they don't have the ability to practice on their own, not under the supervision of either somebody who actually has a license. And then near and dear to my heart are administrators, right? So administrators they're providing a range of support and leadership throughout all different kinds of clinical settings and scenarios. So your entry-level stuff, like kids that graduate from HMP go into, are things like being a PSR or an ASR, a patient service rep. So they run the front desk and they do scheduling for patients, and they and doctors and so forth. Manage revenue cycle work on the very front end. We have revenue cycle analysts, people who work to bring all that money that the physicians are earning into the organization and make sure that bills get paid and sent out. Information systems analysts that work to make sure that electronic health records are working properly. And then there's just lots of other kind of cats and dogs, if you will. Broadly, they fit into a series of administrative functions. So operations, the chief operating officer of a hospital typically oversees the provision of care not from a clinical perspective, but from a workflow perspective. So they make sure that clinics are opening on time and they have all the people they need, and the flow of information and people is safe, and they very much work to make the environment right. So the COO's primary function is to make sure that the environment where the care is being delivered is conducive to that workflow. Finance, which was my area of specialization, provides not only for like billing and so forth, but we build the budgets for the organization, and we help to pay for everything that the organization runs. An organization like Wentworth Douglas costs $350–400 million a year to run. It's a lot of money, and we raise money to build new buildings and start new programs, and all those sorts of things have to be done. Everything, what I like to say is money is the blood of any organization. And so the chief financial officer oversees that process. Information systems. This is everything from the electronic health record, where the doctor is putting in all the information that then generates a bill about your visit, to population health. And we're using the electronic health records now to figure out how to better deliver care, how to even to predict when you might get sick, right? And send you not you because you're young and healthy, but maybe your grandparents, right, or somebody who's older, to start to see, oh, hey, Mrs. Jones got seen over here for this condition and over here for this condition, and based on that information, we think she maybe should have a preventive medicine visit. Human resources. More than half of the budget of a healthcare organization is typically salaries and benefits. And so human resources is critical to running an organization, getting the right people, paying them fairly, attracting the top talent. All that is human resources. Most are not licensed, so most administrators are not licensed. One exception is nursing home administrators. So you're an administrator, that's the name, and you are required to get a license. And I actually I'm a member of the state board of examiners for nursing home administrators here in New Hampshire. And we'll talk more about that when we get to long-term care. So some trends in healthcare staffing. We talked already about specialization versus general practice, and how we've got kind of an excess of specialists. Those are very costly individuals. There's some argument that, well, maybe we could do more with our GPs, our general practice, primary care people, maybe. It's really hard to say because the government intervenes so much in terms of setting compensation that it draws a lot of people who might have gone into family medicine or internal medicine into the specialties because the compensation levels are so much higher. And that has a lot to do with government policy. So physician shortages in rural areas, really tough to recruit high-level practitioners to go up to rural areas. I've got a lot of colleagues that operate out of the North Country in New Hampshire or up in northern Maine. It's really hard to get not only specialists, but even primary care docs. And so big challenges there to run a effective health system when it's hard to get physicians and even nurse practitioners and PAs up into those areas. Telemedicine is playing an important role with that. And then there's just staffing shortages in other rural areas. Staffing shortages in rural areas for other functions, like getting nurses to go up to the North Country is hard too. Other trends, like I said, healthcare delivery organizations spend 50% or more on human resources. So it's really important to think about healthcare staffing. We have a progression of, or one of the things that's characterized by, that characterizes healthcare professions is high levels of training. Many, many years. I showed you some of the examples of, physicians running from 10 to 15 years of training to get to where they are. These are heavily regulated professions, lots of licensing requirements, lots of board certifications. So it's very expensive. These are extensive occupational licensing requirements, and those create a lot of expense. We see a trend towards more and more education requirements for what had historically been less educated or lower levels of educational requirements. So pharmacy, you used to, in my time in my career, the first, through the 90s, you could just get a 4-year undergraduate degree and become a pharmacist. Now they're requiring you to do a doctor of pharmacy or a DRPH, which is a 6-year degree. So you've gone from being able to become a pharmacist in 4 years to a pharmacist in 6 years. That means that people that come out with that degree are going to expect to be paid more to compensate them for that extra 2 years that they spend in school. Physical therapy, in my career, used to be a BS. Now it's a doctor of physical therapy. So we've gone from a 4-year degree to a 6 or 7-year degree. Nursing was common to have a 2 or 3-year RN. Now BSN, 4-year degree, is becoming kind of a minimum. And if you want to make a career of nursing, you almost have to get an MSN. And so as we increase both regulatory requirements and educational requirements, you're going to see an increased cost. Why do we want these higher levels of education? Well, I'd rather be taken care of by a DRPH than a BS pharmacy. I'd rather have a doctor of physical therapy than a BS in physical therapy, but that's not free, right? So every time we raise those requirements and say, nope, you can't enter the field with just a BS. Now you need 2, 3, 4 more years of training. We raise the costs of delivering care. So that's something to think about as we go forward and talk about regulation. Okay, so that's it for professions. Moving on to chapter 5.